Hi, good morning, everyone. Thank you and welcome to Yale Cancer Center Grand Rounds. My name is Sir O'Mara. I'm the Chief of Head and Neck Surgery at Yale, and it's my distinct pleasure to introduce our speaker for today, one of my colleagues in ENT, head and neck surgery, Dr. Suresh Mohan. So Dr. Mohan is assistant professor in surgery in otolaryngology here at Yale. He earned his medical degree from Brown University. He did a 1-year research fellowship at the NIH, and then he actually did a 7-year research track residency at the Massachusetts Eye and Ear Infirmary and Harvard Medical School. Normally, ENT is a 5-year residency program, and so he did an extra 2 years dedicated to research while in training. Then, not only that, he went on to do a fellowship in facial plastics and microvascular reconstructive surgery at UCSF, a very renowned program in this field. Here at Yale, Dr. Mohan's clinical expertise is focused on a lot and everything to do with facial reanimation for patients with facial paralysis. That includes dynamic and static reanimation. He also is a force in microvascular reconstruction for patients with head and neck cancer as part of our team. And he's also expert in Mohs reconstruction for patients with skin cancers. He also, another part of his practice has to do with functional aesthetic rhinoplasty, facial trauma, gender affirmation surgery, and the cosmetic treatment of the aging face. In terms of research, which she's going to talk to us a lot about today, it's all related to clinical outcomes in facial palsy and nerve repair through the understanding of molecular foundations of peripheral nerve regeneration. He has won numerous awards for his research and teaching and has over 30 peer-reviewed publications to date, and he just joined the faculty less than a year ago. It's rare that we bring in a new recruit to the Yale Cancer Center and Department of Surgery where we're actually bringing something new, and that's what Dr. Mohan's recruitment was all about. He is bringing advanced facial nerve, facial paralysis, reconstruction, functional rehabilitation to patients here at Yale. And he's just getting started, but he's already very busy, and we're very, very happy to have him here. And he's going to tell us all about the management of facial palsy and head and neck cancer therapy. Dr. Mohan.
Good morning. Thanks so much, Cyril, for the kind words. It's truly an honor and privilege to be invited to speak here, so thank you all for being here. I wanted to start with talking a little bit how I got interested in facial palsy. I had the privilege of training with Tessa Hadlock at Mass Eye and Ear, who's one of the pioneers and I would say gurus of facial nerve reanimation in the world. And I fell in love with this patient population because not only is it a condition that affects form and function, but truly psychosocial well-being overall. And especially in the context of dealing with a cancer diagnosis, having this life-changing sequelae of treatment, I think, really affected patients in a deep way, and being able to help with that seemed like a really special opportunity. So I wanted to start with what I hope to leave you with at the end of this hour. Facial palsy is not just a physical, visible appearance change. It's a functional problem. It's a psychological problem for these patients. For the longest time, patients have been told, there's nothing to do. I'm sorry, go to Boston or go to New York. And no longer is that true in Connecticut. And I've heard many patients say that and over, and it's a privilege to be able to bring this care here. And finally, facial reanimation surgery reestablishes smile, blink, symmetry of the face, and self-confidence psychologically for patients. So of all the sequelae of head and neck cancer and its treatment, I would say facial palsy is one of the most devastating because of its broad-reaching effects. I could describe to you in words, or I could show you what facial palsy does to the cancer patient. This is Carol. She was diagnosed with an aggressive DLBCL of the neck that invaded the skull base and left her with facial palsy. You can see she can't raise her eyebrows. She can't close her eye. She can't breathe through her left nostril. She can't smile. She can't speak. and she can't eat without drooling. The facial nerves has such broad functions in terms of expression, corneal protection, hair cell protection in the ear, breathing through the nose, chewing and speaking, and its injury leaves patients with functional psychosocial impacts. This picture is special to me because I think in this expression, Carol really depicts what this patient population goes through. Not only is she suffering from a cancer diagnosis, but the stigma of having facial palsy and trying to face the world with this altered condition. So let's take a step back and talk about the facial nerve anatomy. Cortical projections from the motor cortex synapse on the facial nucleus in the pons, and the facial nerve loops around the abducens nucleus and exits at the pontomedullary junction, enters the internal acoustic meatus, traverses the temporal bone, and exits the skull base at the stylomastoid foramen, where it divides into several branches of muscles that supply, different branches of nerves that supply different muscles of the face. Not only does it provide motor movement to these muscles, there are also branches to the greater superficial petrosal nerve, provides preganglionic parasympathetic innervation to the lacrimal glands, and also the stapedius nerve provides protection of hair cells in the middle ear. When we look deeper at the facial nucleus in the brainstem, it's divided into several subnuclei. Each of these nuclei are correlated with a specific function. So the medial subnucleus, for example, correlates to the auricular muscles, so on and so forth. And even along the course of the nerve, there's variable topography, and so different axons are found at different places in the nerve as it travels into the face. This has significant implications for what happens after injury to the nerve and how important the location of the nerve injury is. What causes facial palsy? There are many causes. Probably the most common that you've heard of is Bell's palsy. I will say, I'll take this moment to emphasize the importance of distinguishing between Bell's palsy and facial palsy. Facial palsy is the final diagnosis. Bell's palsy is a type of facial palsy. I think very commonly we hear people use them interchangeably. In fact, they're very different because the etiology determines the treatment. Of course, today we will focus on facial palsy associated with benign or malignant tumors and their treatment. What happens after the facial nerve is injured? The face is in normal condition. It suffers an insult, which results in Wallerian degeneration of the nerve, and the face goes flaccid. If the nerve remains intact, eventually regenerating axons traverse the nerve, and the face recovers. 30% of patients will go on to develop aberrant regeneration or overzealous regeneration that results in post-paralytic facial palsy, or what we call synkinesis. If the nerve was cut, or if there's an ongoing insult, such as a tumor, then the face remains in the flaccid state. On the left, you see one of our patients with flaccid facial palsy for several years, nearly 20, and a patient on the right with post-paralytic or synkinetic facial palsy. You can see these are very different conditions, both categorized as facial palsy. In the cancer patient, the flaccid state is much more common because typically the tumor or the treatment for the tumor results in transection or complete destruction of the nerve. We define synkinesis here as abnormal involuntary movements associated with a voluntary movement, and this begins usually 6 months after an insult. Muscle has a lifespan. Denervated muscle has a much shorter lifespan. And so when you injure the nerve to a muscle, you get 18 to 24 months to reinnervate that muscle before the muscle is no longer receptive. The neuromuscular junctions fade away, and there's no ability to reinnervate. So when we have a facial nerve injury, the sooner reconstruction happens, the better the long-term outcome. The way we think about the face is by dividing it into sub areas, and each zone of the face has a specific treatment associated with it. For both the flaccid state here, I know this is a busy slide, but we'll walk through it in detail. For the flaccid state, as well as for the post-paralytic state. What are the most common head and neck neoplasms associated with facial palsy? From a benign perspective, we have vestibular schwannomas, facial schwannomas, geniculate hemangiomas, and of course, from a malignancy perspective, high-grade parotid tumors such as mucoepidermoid, adenoid cystic, or aggressive cutaneous squamous cell carcinomas are the most common. And as we know, the most common treatment for parotid tumors is surgical resection, and therefore, the most common cause of facial palsy with treatment of parotid tumors requires surgical repair. So what is our algorithm? How do we repair the facial nerve after resection of a parotid malignancy? If the parotid tumor can be removed, for example, with benign tumors with no damage to the nerve, then of course, no treatment is necessary. Sometimes there can be temporary neuropraxia of the nerve from dissection, and that will typically recover as long as there's not a deep nerve injury. If the nerve is transected in the process of removing the tumor, then we have multiple options for treatment. Depending on which branch is transected, periocular work may be necessary for corneal protection. A primary repair of the nerve can be performed, or an interposition graft can be inserted. If more distal branches need to be resected, but the proximal stump of the facial nerve is still preserved, in that case, a static suspension is typically performed based on the age of the patient. Older patients need more support in the face. A nerve transfer can be performed if there's insufficient donor axons from the native nerve. And finally, interposition grafts, again, if there is a distal stump to sew to. In the most radical of resections of parotid tumors, where the lateral temporal bone must be resected into the middle ear, the proximal stump may be absent. And in those cases, we depend completely on nerve transfer procedures to reanimate the face, and sometimes requiring free muscle. So I'm going to walk through each of these strategies and some of the surgical details, and then I will go into some of my research at the end of the talk. So we'll begin with eye care. Protecting the eye, the cornea, is the single most biggest priority in treating facial palsy. And so when we do these radical parotid resections, staging the periocular work is helpful because we don't necessarily know the amount of tightening of the upper eyelid or the lower eyelid that needs to be done. And so I like to stage this work until 1 to 2 weeks after the initial ablation so that the correct lid weight can be placed or the correct amount of tightening of the lower lid can be done. From a static perspective, we teach patients to do lid stretching and eye patches. So this is the lowest option on the totem pole. When patients develop paralytic lag of thalamus from injury to the facial nerve, they can't close their eye, usually because the upper eyelid is unable to come down low enough to cover the cornea. By stretching the upper eyelid on a consistent basis, 1 to 2 millimeters of improvement can be obtained. Moisture chambers are used to keep the cornea moist. Next step up from this is performing a lateral tarsorrhaphy. And so this is basically a procedure to close the lateral aspect of the eye, and this helps with corneal protection. The downside to this is it's very temporary, doesn't last very long, and patients can have irritation from the suture being there. There's also decreased palpebral fissure width, and so vision can be occluded, and also the a cosmetic appearance of half your eye being closed is problematic for patients. The next option we have to close the eye is by adding weight to the upper lid so that it descends further. The way we do this is by using a test weight before the surgery to determine the exact amount of weight. It's usually around 1.2 to 1.4 grams. And we used to do this with gold weights. You may have heard of that. But the problem with gold is that it's very reactive, can trigger inflammatory reactions. Also, it has a high density. And so nowadays we use platinum because it's lower density, so you can produce a thinner profile weight that's less likely to extrude and achieves the same effect. And this comes in both a chain or format or just a regular profile. And so here You create a pretarsal or supertarsal pocket, insert the weight, and secure it. What about for the lower eyelid? The other way we can tighten the lower eyelid is something called a lateral tarsal strip. So here there's a lateral canthotomy being performed with an inferior cantholysis. And so the inferior tarsus is released away from the canthus and the edges are stripped, as the procedure name indicates. And then this is sutured to the Whitnall's tubercle, or the prominence on the medial aspect of the lateral orbital wall. And by doing this, we're able to tighten the lid. And you can see here a patient who's had the procedure. He had ectropion before and able to achieve much better eye closure with the tightening. And in some cases, the lateral tarsal strip is insufficient because they have medial lag ophthalmos in addition to the lateral portion. So in those cases, we'll perform what's called a lower lid tarsal sling. And so you can take fascia from the leg and thread, think of it as a belt for the lower lid. And so you secure it to the lacrimal bone medially. Here, you can see it's being tacked to the bone medially and brought through between the anterior posterior lamella across to the orbital rim laterally and secured there. And this improves the medial lag ophthalmos. Everything we've talked about so far is static. Is there a way for the upper eyelid to blink again? Indeed, there is. So dynamic blink reanimation has been growing in popularity in the last few years due to some novel techniques. So here, what's done is a cross-face nerve graft. So a nerve graft is harvested from the leg, and you find a suitable eye closure branch on the other side that has redundancy. You connect it to that nerve, and then you tunnel it across the forehead and bring it into the upper eyelid on the other side. In the second stage of the surgery, 6 months later, you come in with a free muscle graft and allow the nerves to grow into the muscle. And as this happens, the eye is able to blink once again. So this is a patient that came to me with flaccid facial palsy after a cerebellar hemangioblastoma resection. And so I performed the first stage here. You can see the nerve is brought through into the upper eyelid. And she also had a graft for a future smile reanimation. And the fascicles are splayed here. And so her second stage is coming up in 6 months. Free muscle transfer for blink reanimation has also been described. A cross-face nerve graft can be placed, and a free platysma flap can be taken, and muscle strips placed in the upper and lower eyelids to reestablish blink as well. The problem with this technique is it's very laborious, and the outcomes are not nearly as good as the dynamic blink we just saw. Okay, so we talked about the eye. What about the nerves that have been cut after the tumor was resected? So we can repair those nerves with either primarily, if they're close enough together, or with a graft, if there's too much space in between them. One of the fundamental tenets of nerve repair is a tension-free coaptation. This was a case from residency where a parotid cancer was resected, and the superior division of the facial nerve was transected, and the surgeon brought the ends together and sewed them, as you can see in the top right. Unfortunately, it was under significant tension. And it was eye-opening to me because we actually took the patient, even though the nerve was repaired, we took the patient back to put in an interposition graft because of the tension. And so I looked more into where did this tension concept come from? So it began very early canine studies in the 40s. This was a study where they used primary repair or interposition grafting, and they used interarterial lead injection. So you can see on the right side here where they perform a high tension repair versus interposition graft, and you just have much better vascularization of your distal segment inferiorly here with using the interposition graft. So this is kind of where the concept of avoiding tension in nerve repair began, and why it's so important in the face as well. There have since been other strategies that have been developed using nerve wraps or other ways to mechanically distribute the tension. As you can see, these wraps can be sutured at other parts of the nerve to minimize tension at the actual interface Nerve lengthening procedures. While this sounds counterintuitive because we know neuropraxia is damaging to nerves, when stretching of the nerve is performed in a slow fashion over 20 minutes, you can actually take advantage of the elasticity of the nerve to improve tension. And finally, this was a product that came out recently where there are micro hooks in the wrap that can actually hold the nerve together to reduce tension as well. Okay, so if we have nerves to repair, we've done that. What about for the flaccidity of the face? So let's move on to the static suspension. So this was a gentleman who came in with a who needed a radical temporal bone resection and parotidectomy with facial nerve sacrifice. And so for him, we performed amongst other things, a static suspension here. And so the way we do this is we take fascia from the thigh, the fascia lata, and then we cut it into strips and attach it to different points in the face. Here you can see to the nasal base, to the nasolabial fold, and to the oral commissure here. And while it's not a dynamic movement, it does help with resting position. And here he is 3 weeks after. And functionally, this improves drooling. That's probably one of the main things, and also breathing. So the nose here collapses, and so being able to pull that valve laterally improves airflow through the nose, improves drooling, and appearance. This is another gentleman who you can see on the left side here had a static suspension along with a direct brow lift. And you can see also how the brow can really descend and cause dermatochalasis and vision occlusion as well. So both of these are important techniques. Okay, so we've addressed the midface. What about dynamic movement of the mouth and upper lip? So this is what takes us into our nerve transfers. And so when you don't have the native facial nerve driving the muscles of the face, you need alternate nerve sources. And so that's where nerve transfers come in. So we can use the contralateral facial nerve, which is great because it provides spontaneity. And then we can also use the trigeminal nerve on the same side or the opposite side, the 12th nerve, the ansa, or even the spinal accessory nerve. So the crossface nerve graft, the way this works is, so in this scenario, the patient has weakness on the left side of her face. And so what we do is we harvest a nerve graft, again, and open the face and find a branch that's redundant and connect it to here. So when the graft is connected and brought across to the other side of the face, whatever this is connected to will have the same function. So it'll mirror the function of the healthy side. And so this is a very powerful technique that we will revisit here shortly. This can be done for the smile or the eye, as we talked about earlier. The next is the masseteric nerve. The masseteric nerve is the branch that control of V3 that controls the mascatory function of the masseter muscle. And you can see here that the nerve is basically, because there's redundancy of the muscle, the patients don't have any donor site morbidity in terms of not being able to chew. The nerve is then connected to a distal branch of the facial nerve, and so when they bite down, instead of chewing, they can smile. What does that look like? And relax. And now give me a gentle smile, biting down. And relax. Give me a big smile, biting down. And relax. So you can see here when the patient, one second. The patient bites down, he's able to smile. And so the reason is because the masseteric nerve has excellent axonal load. Nearly 1,500 axons in the masseteric nerve compared to the facial buccal branch, which only has about 800. And by the time we connect that branch to a crossface nerve graft, there's only about 200 axons or 100 axons that make it across the face. So this is him. He had a salivary ductal carcinoma and had a radical parotidectomy that left him with this appearance on the left side of the face. And again, with the 5/7 transfer, he's able to reestablish smile. This was a young child with an AV malformation. You can see she has weakness on the right side after the 5/7 transfer. She bites down with teeth. And she bites down, closed smile. So very powerful technique. Downside is it's voluntary. It's not spontaneous. You have to remember to bite down to be able to smile. And so an important part of it is the physical therapy that goes along with this in terms of making sure patients remember to use it and to bite down when they want to smile. Another example of a patient. Okay, what are other nerves? So the hypoglossal nerve, the 12th nerve, is also a donor source. It can be used when the main trunk of the facial nerve has been transected, and it's mostly useful for tone, but sometimes for movement. Of course, the risks are tongue weakness, dysarthria, dysphagia. Here was a patient who had a facial schwannoma that was resected in an outside hospital. The facial nerve, of course, was injured, and there was no proximal stump to be identified, and therefore the 12th nerve was transferred. And so you can see here, for her, she has to move her tongue against the side of her mouth to be able to smile. This is her at rest. And that's her pushing her tongue against her cheek. Again, voluntary is the downside. So this was a group from Spain who published, so the technique here is actually a side to end, so we don't take the entire hypoglossal nerve. So you maintain function of the nerve by only taking 1/3 of the axons, and you're borrowing basically a portion of it with an end-to-side technique. So like we talked about, for these voluntary nerve transfers, it's really important that we have facial rehabilitation that goes along with it. If they are not taught to use it, it's like anything else. It's not functional and not useful to the patient if they're not trained to use it. So we take facial rehabilitation very seriously. We have a strong partnership here with our physical therapy department, and we recently had a visiting lectureship as well. And so focusing on neuromuscular retraining of the muscles is a important part of this. You can see here.
Smile out by relaxing the tension in your eye and in your cheek and in your neck muscles. So form a small smile, and at the same time you smile, you're going to relax the tension around your eye and into your cheek, focusing on the cheek muscles, forming the smile motion. I think of it like your cheek balls trying to form. There you go. That motion. Excellent.
So you can imagine this takes a very cooperative patient and a very understanding therapist to make this work. Okay, so we've talked about static options so far. How about dynamic smile reanimation when we're outside of the window for nerve transfers? So nerve transfers only work if the native musculature in the face is still alive. Like we talked about earlier, the native musculature only survives for 18 to 24 months after the injury. So if you're 5 years out, nerve transfers are not an option for you. So in that case, we need to bring in fresh muscle that can be innervated. And so that's what we do in this scenario. And so here, there's multiple options of muscles that can be transferred for dynamic reanimation. The temporalis tendon can be brought down to connect to the oral commissure. Even the masseter muscle has been described to be transferred over. And from a functional muscle, free flap perspective, many muscles have been used, but the most common remains the gracilis muscle. So how does the temporalis transfer work? Here, remember the temporalis muscle assists in chewing. And so when we flip the muscle down, when it contracts, it can pull on the oral commissure. Another way to do it is with a orthodromic tendon transfer. And here, the coronoid process is actually osteotomized and brought forth to connect to the oral commissure. And this is accessed through a nasolabial fold incision or intraorally. And this can cause smiling with biting down, just like we would expect with the 5/7. When we have to do free muscle transfer, we go to the leg and we harvest a muscle flap with a nerve supply, the anterior obturator nerve, as well as the blood vessels to the muscle. And previously, they've already had a first stage cross-face nerve graft placed for spontaneity. And so when you bring the muscle in and connect the blood vessels and connect the fifth nerve, you can get a nice smile, again, in a patient who's out more than 2 years out from nerve injury. And in children, they have such remarkable nerve regeneration that you don't even need to go to the masseteric nerve. Just a cross-face nerve graft, despite the lower axon load, is sufficient to produce a smile. You can see here, this is her spontaneously smiling. And of course, this is our gold standard outcome. To be able to smile, not have to think about it, and it just works. There are variations of the gracilis, not just using one nerve, but using both nerves, using the masseteric nerve and the cross-face nerve graft, as you can see here, as well as the masseteric nerve as an insurance policy. If the cross-face nerve graft, one of the downsides of this procedure is that while the spontaneous smile is our gold standard, the procedure fails nearly 30 to 40% of the time. That is an unacceptably high rate in adults, at least. There are also variations here where you can do intramuscular dissection and do different vectors of muscle. Of course, the smile mechanism takes nearly 10 different muscles to engage a smile, and so only one vector is only, it's a small piece of the pie in terms of what allows natural smile. And so variations here, putting in a muscle graft to the lower lip can allow lower lip depression, which is normal when we smile. So of course, with our cancer patients, what about after surgery? What about adjuvant radiation? How does that impact our repairs? There's not great data, mostly because facial reanimation still remains fairly uncommon at the time of radical resection. Though it's improving, this was a small study that looked at 39 patients, and they found no significant difference in House-Brackman outcomes between patients who had radiation and didn't. So it supports a theory that getting radiation should not preclude upfront nerve repair. Timing of facial nerve repair has also been brought up as an issue, but we know that time is muscle. So it's very clear now that the sooner you repair the nerve, the better outcome. But a recent study looked at almost 11,000 cases of parotidectomy and found that only 24%, 25% are undergoing reanimation at the time of facial nerve sacrifice. So I think that is an indication of how much room we have in terms of improving outcomes for patients. So as I mentioned earlier, the failure rate in this procedure is 30 to 40%. And many theories have been proposed as to why, but one of the prevailing theories is that as these axons start from the contralateral side and are growing across, Schwann cells in the distal nerve graft lose their ability to support regeneration. And so by the time axons make it across, very few Schwann cells are alive to support and get the axon into the muscle, into the neuromuscular junction. And because of that, the procedure fails. So this got me interested in thinking about what are these repair Schwann cells doing at a molecular level? What is the state that gets turned off? And how do we keep that state for a longer period of time to maybe allow better regeneration? So when a nerve is cut, the distal nerve undergoes Wallerian degeneration, and the Schwann cells that were myelinating Schwann cells take on a repair phenotype. And we know this is a transient state. So the repair Schwann cells come from either the myelinating differentiated cells or the non-myelinating Schwann cells. And they become repair Schwann cells after injury. Macrophages are brought in for breaking down the myelin debris. There's an inflammatory response. So this led to the question, can we exploit the repair Schwann cell response to injury to improve regeneration outcomes? So our objectives were, first, what cells are in the facial nerve? Can we characterize this repair Schwann cell phenotype at a transcriptional level? And can we potentially identify any therapeutic targets? So what did we do? So I used a murine facial nerve transection model. So as you see here in figure 1, the right side of the face of the mouse is shown here. Of course, the mouse facial nerves are sub-millimeter, but we harvested, so first we opened the face and performed an injury and closed up on one side of the face. 5 days later, we came back, harvested the nerve from the distal nerve from the site of transection to the distal buccal branch, and then we harvested contralateral facial nerves that are healthy for controls. We took those nerves, dissociated them down, and ran them through the single-cell sequencing platform, 10x. And then what did we find? So here we're looking at something called a fate plot. Each dot on here represents a cell. And as you can see, the difference in each color represents a different cell type, as shown on the right. When you compare between the wild type or healthy condition and the injured condition, there's obviously a new cluster that has shown up, and this correlates with the repair Schwann cells that we'd expect. When you do an ontology analysis, they have expected gene functions, axonogenesis, guidance, and restructuring of the extracellular matrix as Schwann cells undergo conformational changes to allow for reinnervation. We do a DE analysis, and we found several genes that were correlated with the repair phenotype. Some of these upregulated genes were established, and some of them were novel. So to understand this better, we used a technique called RNA velocity. I wanted to be able to, ideally would look at several different time points, but for anyone who's done single-cell RNA sequencing, you know it's very expensive. And so there are bioinformatic ways of trying to understand gene trajectories without doing every time point that you have. I explain it this way. You see a picture, but what was happening before and after? Can you use what's in the picture to give you a sense of the trajectory? So that's what we did. And the way RNA velocity works is it basically takes the ratio of unspliced to spliced transcripts and can predict the number of genes that are moving at that point in time. It's kind of like taking the time derivative of gene expression to get a sense of trajectory. So when we look at this map, we see that in teal are the myelinating Schwann cells, in olive are the non-myelinating Schwann cells, and we see vectors of differentiation towards the repair Schwann cell phenotype in blue. In pink, we see the macrophage cluster also showing differentiation as we'd expect because they have similar functions in breaking down myelin. And when we zoom in here, again, we see that 5 days post-injury, there's a significant increase in the repair Schwann cell phenotype. So what are the genes that are driving this transformation? We performed a driver gene analysis and identified a few different genes that had the greatest impact. But we, so far, had been looking at individual genes, but we know that genes don't work in isolation. So we did a regulon analysis, and a regulon is basically a regulatory network of genes. And that way we can understand what is impacting what in terms of downstream and upstream effects. And so with the regulon analysis, we found that the ATF3 regulon had the highest specificity. So when we look at the cluster, we see here in the bottom right that this correlates with our Schwann cell, a repair Schwann cell phenotype. So we realized that the ATF3 regulon was very specific for this cluster. What are the genes in the ATF3 regulon? It came up, we were able to narrow down from thousands of genes that are involved in nerve injury to a couple, to 16. And of these, GAL3 was the most expressed. But how do we know that these in silico findings are truly reflected in biology? So we went back and did validation with in situ hybridization and found that indeed GAL3 is upregulated after injury in our cell population as well. And our positive control was C-Jun, which is a well-established marker of injury in nerves. So in conclusion, we've performed profiling of the facial nerve cellulome. We've identified driver genes and found that the ATF3 regulon and GAL3 may be a targetable effector of the program. And next steps would be trying to assess this in a more realistic cross-face nerve graft model. We have models with fluorescent reporter mice where we're able to harvest the nerves and look at specific transcriptional changes. And then potentially create a knockout of the GAL3 gene and see impacts on nerve regeneration. I'd like to thank my collaborators and mentors, and specifically my Yale otolaryngology family, Ben Judson, Sarah Mera, Zafar Syed, and Sarah Pei. Thank you all for being here, and those who are not here, thank you as well. It's been a wonderful year so far, and I'm excited to help grow this program. We have over 75 patients already in a year. We're rapidly growing as word gets out. We're getting a lot of referrals from people who are going to Boston and New York and want to bring their care back to Connecticut. We have several reanimation procedures going. We got multiple clinics, established workflows. We had I mentioned the physical therapy visiting lectureship. So it's a very exciting time at the Facial Nerve Center, and I'm very grateful for all the support. And I leave you again that facial palsy results in not just visual appearance, but functional and psychological sequelae for these patients. They have, nearly every patient has an option for improvement in their condition, and we have ways to reestablish smile and blink. And I think that's all I have. I can take questions. Thank you so much. Dr. Syed.
Suresh, so yeah, I want to really applaud you for all the amazing work you're doing and the fact that you're able to bring this here at Yale and to Connecticut at large. With regards to the gene expression, for GAL3, for example, are you able to tell if there's differential expression across the nerve that you took, like proximal versus distal? Is that something that needs to be looked at?
Yeah, absolutely. Yeah, so the question was, is the repair Schwann cell gene expression variable across the length of the nerve from distal to proximal segment? And that's a very good question. We know that there are, by definition, the proximal segment is not injured. And so although there are changes at the level of the facial nucleus as soon as exotomy occurs. So the short answer is no, I haven't done it yet. But yes, there are expected changes, and I think it would be very easy to do. It's just multiple time points, and at the time, I didn't have the resources to do that. But great question. Sarah, yeah.
Great talk, thanks so much.
Yeah.
Was wondering if you guys were going to look at the potential interacting ligand to the GAL3 and whether it's this key lock kind of mechanism that's.
Absolutely, yeah. I think the next step would be trying to, yes, sorry. So the question is, have we done a ligand analysis for GAL3 and looked at what's interacting? And absolutely, we've found several chemokines, and I think there are some GPCRs that are also involved with GAL3. And so I think our sample size was not high enough to be able to get significant data on the ligand analysis, so we kind of ditched it, but that is definitely on the table. Barbara.
Yeah, so amazing work. For the patient who, let's say, has a parotid tumor, you know that you're going to be doing chemoradiation. Are there any particular considerations in our, let's say, adjuvant treatment planning? Are there particular nerve branches if the person needs contralateral neck that we should be paying attention to so you have the optimal nerve to?
Yeah, that's a great question. Question was, in the patient with a parotid tumor who is expected to need chemoradiation afterwards, are there any considerations about what nerves to preserve or protect? If we're doing upfront facial reanimation, then it doesn't really change, I think. I think the prevailing opinion has been like, do your reanimation early, and then whatever treatment they need to get anyway. And so I don't think anyone has thought of a way to alter their management. The only thing that might be different is,
I'm sorry, you're saying do the reanimation and then radiate that,
yeah, so
those transplanted nerves and.
yeah, so it turns out that the data on radiation of the nerves is not as bad as initially thought. You know, that for a long time people are like, oh, if you're going to get radiation, don't bother with facial reanimation, and the outcomes are not that different between. And so that's why now there's a push to just do it up front, because then patients end up not getting it, or for whatever reason. So I think that's my strategy currently. Okay, thanks so much.
All right, thank you, Dr. Mohan. I have one more question for you, and as I moderate and end this. So it sounds like you have some great opportunities here at Yale for research, not only basic science, but also in clinical outcomes, like the question that was just asked by Dr. Burtness, what are the outcomes? I think there's a great opportunity here with the high volume of head and neck cancer we have. Have you found any collaborators at Yale Cancer Center or at Yale in nerve regeneration? Or are you looking for some? And how can people contact you if there are some people listening who might be interested in working with you?
Thank you. Yeah, I promise I didn't plant him for that. But absolutely, I am very eager to continue this work, and I've been trying to find the right collaborators and just haven't exactly found them yet. So please do reach out, email. It would be great. And I think there's an opportunity to be able to bring tissue from the operating room and really do this, because so far all the work has been in mice, and so being able to bring human tissue into play would be great. Thank you.
All right, thank you, everybody.